Hello and welcome. This is Paul Tunner from Pharma Forum. I'm glad you could join us for today's live webinar, Partnering with the NHS in a Crisis. Now, crisis is quite a big word, but we know the NHS is under incredible pressure, and it was even before the pandemic. And as we hopefully come out of the pandemic, it's facing even more challenges. There's incredible strain on the system, on budgets, and on the people. And that means something needs to change and creates an environment for partnership, which is our topic for today. Thank you to IQVIA for sponsoring this webinar. You can also follow on Twitter if you're tweeting, hashtag #PPWebinar. You can throw questions in, follow the debate. And I'm joined as always by an absolutely fantastic panel. I won't do big introductions, but so you know who's speaking, and this is the order they'll be speaking in. We have Steve Jarrett from IQVIA, Deborah Mitchell, who's joined us from the NHS side from Leicester, Veronique Walsh, Dr. Veronique Walsh from Gilead, and Jim McArdle also from IQVIA. They'll be presenting their views, but we want to take your questions. So as we go through this, please throw your questions in. We'll take as many as we can. And we will be asking you to comment on a couple of polls. And the first poll I'm just going to launch now, because we want to see how optimistic you are. We know it's a challenging environment with funding for Beyond the Pill, which is a big topic of today. So the question here is, and I'll start the poll, what will be the impact of the current environment in terms of investing in Beyond the Pill solutions over the next 2 years? We have 5 options. Do you think funding will be completely blocked? Will there be a significantly negative impact, a slight negative impact? Things will stay the same, or do you think it will actually increase funding for these initiatives? So you can cast your votes on that. We can't see how you're voting. Don't worry, it's all anonymous. And I'll leave that running as we go through our first presentation. And so the order today will be Steve will set the scene for the background on this. We'll then hear from Deborah, the NHS perspective, living and breathing in it every day. Veronique will talk about thoughts on how the industry can support. And then before we go into more of a structured discussion, Steve and Jim will just summarise some areas that we could focus on. And as I say, we'll take your questions as we go through. So without further ado, Steve, I'm going to hand over to you to set the scene.
Thank you ever so much, Paul. And thank you everyone for joining. Hopefully you'll get a lot out of the next hour of discussion between us. And well done for those around the table for making it through school strikes, tube strikes. We're actually here next to each other. Look, you can see my hand in other people's screens. So we are in one place. Just to set the scene, I think first thing I want to call out was that our strategic market access team recently published our 2023 Peshtal analysis. And that is not me doing a terrible impression of Sean Connery. I genuinely stating it as a fact. We call it a Peshtal analysis because we brought healthcare and social care into the mix of what we've kind of looked at here. And one of the key call outs from that piece of work is really how the NHS and industry can collaborate. And I think it's fair to say that as a result of the pandemic, actually quite a remarkable amount of collaboration took place between the NHS and the life sciences industry. And it ultimately enabled us kind of to be sat in this room again to have this conversation. So I think that's an important anchor for our discussion today as to, well, that we've achieved an awful lot. How do we make sure we sort of keep pushing on with that as we go forwards into 2023? So let's make sure it's sort of a catalyst for our discussion today. So on to the next slide, I thought it'd be useful just to kind of call out what crisis looks like for the NHS and for those accessing care at the moment. And unfortunately on the slide that I have in front of me, even though some of these charts go up and some of them go down, none of them paint a positive picture, despite which direction they're heading in. Okay, so we know that waiting lists for elective care have increased dramatically over the past several years, and despite new investments coming in to solve some of these problems around workforce and capacity issues and diagnostics. Likewise, when we're looking at the emergency department attendances, we're in a very challenging situation around that, in a circumstance at the moment where actually the people who operate those services are also kind of withholding capacity to some degree, as is their right. So there's compounding issues regarding how people can access care through different avenues at the moment. And then when it comes to people actually being seen in a timely fashion for cancer referrals, the trajectory has not been a positive one on that front either. And so I think it's just important that we can kind of sort of see what the actual impact of the kind of state of crisis that we have and how that can kind of play through in the statistics. And one kind of aspect of that I think really sort of distills down what this challenge looks like is that you kind of have this effectively sort of two-sided issue where you've got increased demand coming through the system, as you see on the slide image on the left-hand side of the screen at the moment. Okay, so we know that there are increased referrals coming in. We know there's been a bolus of patients that haven't been able to get access to the care that they really needed as a result of the pandemic, and now that's started to come through in increased demand. But really interestingly, you can see on the right-hand side of the screen is that actually the number of incomplete pathways, and by which that means those that have accessed their care journey that are then kind of stalled on that care journey, right? They're not able to finish their pathway. They're not able to move to that next step. We have 6.7 million additional patients who are sat on their care pathway that otherwise you would expect it to have sort of moved through that system and received the care they're delivering. So this kind of cumulative impact on our NHS at the moment, I think, is really where we're starting this conversation today about the crisis that we're facing and the potential opportunity for life sciences industry to hopefully be in the mix to really help sort of push forward and resolve some of those complexities we're seeing play out on the screen. So this is a bit of a secondary care picture. Jim, I know you've got a couple of examples of the primary care side as well, because it's not exclusive to secondary care.
Yeah, thanks, Steve. So happy to talk through the primary care landscape. So, I mean, one thing we know is there has been a significant increase in GP workload. If you look back from 2019 through to 2023, there's been an 18% increase in GP workload in that time. That has been done against the backdrop of fewer GPs operating in primary care. So the net reduction is around 700 in that time. And because we have a reduction in the number of GPs, we have an increase in our GP to patient ratio. The average GP caring for 120 more patients per GP. At the same time, we have more doctors leaving than joining the profession. And there's evidence that GPs are working above and beyond to deliver that enhanced capacity. In October 2022, there were 36.1 million GP appointments delivered in primary care in 1 month. And of those, 40% were delivered on the same day booking. Now, I think that is phenomenal effort from our colleagues in primary care. The challenge, though, is that long-term condition management is still running at less than the pre-pandemic levels. And GPs have just had a new contract foisted upon them just last week on the 6th of March. And what's interesting is access is a central theme to that. Now, I would argue that they're doing a great job with access, but they're still wanting more in terms of pushing forward. And there is going to be a release of the new delivery plan for recovering access to primary care. Now, there's a couple of levers that are happening. One is around the Impact and Investment Fund, and there's been a shrinking of the number of indicators from 36 down to 5 for the IIF. What's really interesting is there's some key elements are left in there. So one being early cancer diagnosis. Now, I think this is a real opportunity for life sciences to partner with the NHS to support. The other key consideration to think about is I think there's going to be a fundamental change to QoF for 2024-25. And I think what we're going to see is in 23-24 is almost a stagnation, if you like, of how QoF is managed within primary care. That potentially poses a challenge to long-term conditions management in 23-24. And I just wonder if that's also an opportunity for life sciences to help support the NHS. There is some good news. It's not all bad. There is some good news in that there has been strong recruitment via the R's roles, and I know, Deborah, you'll talk to that later on. And there's been an increase in not just the number of roles, the type of role, but the volume of roles. So again, driving that access. One challenge we have is that the BMA stance on the proposed GP contract is they've initially rejected it. So we could reach this impasse between primary care physicians and government. We're also seeing similar with the junior doctor challenge as well within secondary care. So it's all about access. It's all about how do we drive patient centricity, but we've got to bring the workforce along with us, both primary and secondary care. And I think with that, I shall pass over to Deborah.
Thank you, Jim. And sorry, Deborah, just to comment, I know a couple of you commented saying it's a little bit quiet on the sound, some sound issues. We have tested everything. We know others can hear us, but apologies if you are experiencing issues. We're all round a central speaker, so I encourage the presenters just to lean forward and make sure we're speaking at a good volume. I don't want you to miss any of this great conversation. Deborah, over to you. So your view from inside the NHS. We'd love to hear your thoughts.
So thank you. And just to say, I've been a manager in the NHS for more years than I care to remember, about 34. And this is my personal view as opposed to an official NHS view, but I think it's one that's probably shared with many. So I'm going to cover what crisis looks like for patients, picking up on some of the comments already made, why the NHS is in this situation, what we're going to do about it, so what the plans are to date, and what opportunities I think there are for industry and pharma to help us. This slide says it all to me. What keeps me awake at night, from my husband snoring, is trying to deliver the two duties that leaders in the NHS need to fulfil, and that's to take care and meet the needs of patients and look after the health and well-being of staff. And it becomes a circle of pressure between those things. And one of the biggest places that pressure is seen is in ambulance handover waits and waits for an ambulance. Response times. If you're at home, you call an ambulance, you don't know how seriously ill you are, there is nothing more scary than that wait and not knowing when that ambulance will arrive. And all of the publicity that we constantly, you turn the television on, you pick up a paper, there are constant reports of long waits. And now with the strikes that we're seeing, and we can very much understand as leaders why staff are going on strike, but the impact that has on patients and that confidence becomes that circle of pressure. Thanks. So on the ground, we've heard the massive number of primary care appointments that there are now, higher than pre-pandemic, but demand does not outweighs that supply. And often patients default to emergency departments, and that has an added pressure in hospitals because sicker patients generally would come by ambulance, and walk-ins would be less sick, so it would allow staff to manage those flows. More patients are making their own way because they can't get an ambulance, and the risk in the emergency departments increases with that pressure. Bed occupancy and length of stay have increased, so despite that demand being there, we haven't had a huge growth in admissions, but length of stay is increased because patients are stuck in the system, and they're stuck into the system because of blockages in social care. Lots of our patients need to go out on pathways in social care, and cost pressures there have a real effect on that throughput. We've heard about cancer performance being significantly challenged, and one of the big elements of the long-term plan was about reducing health inequalities. There's very little time available for us to address that, and again, that's a real opportunity for industry and pharma. Public expectations not declined, and when we talk about the R's roles, there are different ways that you can see and be dealt with in primary care, but the public still believe they would need to see a GP. So we've got a lot to do to work with the public on public expectation. And again, I think there are opportunities with that. Tired and broken workforce results in inefficient processes within the NHS, and what's more important, increased risk. So main factors affecting the storm are threefold: workforce, demand and finance. We've heard about the workforce shortages. 1 in 10 social care and NHS posts are vacant. And in 12 months from September 22 backwards, 148,000 patients resigned from the NHS, which is almost a third more than the previous year. And so trying to keep pace with that workforce, and we've now got one of the lowest doctors per patient and nurses per patient in Europe. In terms of demand, we've got population increases, we've still got the backlog from COVID, And just as we're trying to get through that backlog, along came one of the first flu pandemics in the last 10 years. Long waits for over 12 months, 239 times more people waiting over a year than in December 2019. I mean, that is phenomenal. And those patients on that waiting list are deteriorating. So when they come for treatment, it's much, much harder to do it. Median waiting times have also increased to 14 weeks from 8.3. And we can't hide away from the financial issues. The NHS has been in financial problems pre-pandemic. There's been lower funding since 2008. Cost of delivery in healthcare is also more expensive because of the implications of infection prevention and lower throughput, again, to protect patients and staff. And the local authority cuts affecting social services has a massive increase on the NHS. So what's the NHS doing about it? The operational plan for 23-24 offered the potential of a fresh new look and to take away some of the pressures from the NHS to focus on reducing that backlog. And while we recover that backlog, we need to move towards meeting some of the long-term plan. The biggest problem that we have, though, is we can't do it unless we transform, and we struggle to transform on our own. So what else is going on? So the deliverables in the planning guidance have reduced from 80 to 30, which might sound good. If you take the cancer ones, they've gone down from 8 to 2. But in order to deliver those 2, you still have to make progress on all of those other targets. So we need to approach the whole pathway and being able to engage from patients through all sectors. The ICBs are now being encouraged to work together, making scaling up transformation and change easier. So again, that's a big opportunity for pharma and for industry, because with people working together and coming up with joint solutions, it's easier to make that impact. Talked about ours roles briefly. Not everyone needs to see a GP, but we need to do something in getting the public engaged in that process. And one of the biggest challenges for primary care, we've heard about long-term conditions not keeping pace. GPs are best to manage long-term conditions, yet they are being forced to do more of that direct acute care. We need to be able to use the roles, but also to work with industry to ensure that the patients can maximise the amount of self-care that they have, as well as seeing a doctor. Pathway transformations, there's loads going on. Virtual wards, remote monitoring, prehabilitation, getting patients ready for surgery when they can finally get to the end of that waiting list. And urgent care hubs where we're bringing together multidisciplinary teams to try and keep patients out of hospital. There's lots of opportunity to scale up those transformation areas. So in terms of collaboration, what's the appetite for pharma to support the NHS beyond the pill? I think one of the key things we need to get to is we need to get the NHS to pitch to pharma and industry rather than the other way around. A joint solution to be able to get time to form those solutions. We need the expertise. We need expertise in workforce. We don't just need the science and development. We need to be able to draw in all of the skills in industry to help us solve the problem. One of the things and partnership working that we need to link with is health and wellbeing boards, that we bring social care and healthcare together with industry and pharma. And I think that would allow us to move on to more strategically planning some of the solutions in the NHS.
Thank you, Deborah. That's a really thorough perspective of, as you said, your kind of personal views on what's happening within the NHS, but you're there on the ground. And I think any of us on this webinar or listening and watching this webinar will know from our own personal experience, you go into any hospital, you can see the pressure that the NHS is under. So something definitely needs to change. So it also teases up quite nicely, Veronique, for your perspective. Before I go over to you, I want to just take a look at that poll that we launched earlier. I'm going to close that poll just so we can see what the results say. It's just a straw poll, as ever. Doesn't mean we need to take too much from this. But we asked you what the impact was of the current environment in terms of investing in this kind of partnership and beyond the pill solutions. Now, my take on this is it could have been worse, actually. So 3% saying funding will be completely blocked. 46% say a significantly negative impact. We're in a very tough environment. 26% saying a slight negative impact. 3% think things won't change, but 19% of you think funding will increase. So I'll take an optimistic slant on that. I don't know about anybody else, but that probably teases up quite nicely for your thoughts, Veronique, around what could the industry role be in this particular scenario.
Thank you very much. So first of all, I'll as an introduction, I would like to say that I work from Gilead Sciences, but what I would like to do is to give an idea and illustrate by practical example of partnership. I would like to illustrate how the industry could support the NHS with really the aim to make a difference for patient outcome. So when we're talking about Gilead, what we say is our purpose is really to make the world a healthier place for everyone. And what we've heard from you, Deborah, is that at the moment with the situation in the NHS, we're leaving, in fact, some patients are not getting the care, either the incomplete care or are not getting the care they would deserve. And it's a situation where we need to work in partnership, as you've mentioned, a transparent and genuine partnership where we can make a difference for the patient. So here, the way I see the role of the industry is not only limited to developing and making available innovative treatment, but it is also to create that partnership not only with the NHS but also with the third sector. To make sure that linkage to care is significantly improved for improved patient outcome. In a way, I live in the UK like you. I'm a potential patient and I'm biased because I want to make sure it is working. But it's also because I'm trained as a medical doctor that I remember how, having seen it personally, how that partnership can make a real difference. So in a way, I'm positive because I believe it is possible, and my objective is to show you example that has been happening. So NHS partnership to delivering improved outcome for patient. So I'll give you a few examples. But overall, what I would say is, yes, pharma can offer support when we have shared aim. And I know we've discussed before, Deborah, that what is really making is spending a little bit more time at the beginning to understand what is a win-win. In fact, the win for NHS, the industry, but also more importantly for the patient. And what is the shared goal? Where do we want to work? What is the leadership? Looking at the governance, because it is true that the pharmaceutical industry has a very clear set of rules, and that is also to protect the patient. So let's see how we can work. What the goal we're working on? Put the patient in the center and just checking really what is the need. Sometimes working with peers so that the patient voice is there very close to us and making a difference. And what we have to offer sometimes is about digital and data solution, resource to optimal patient pathway. It was interesting in what you presented, the fact that incomplete pathway is a real problem for long term. And also involving these third party who are making the voice of the patient much more present. And I know that it happened because during the COVID, what we've seen is we were all in the same crisis. And we put a lot of innovation working together. And as you mentioned, remote consultation. I would say before COVID, we didn't think it was possible. And having the pharmaceutical industry at the same table as the NHS, in a genuine conversation, saying, what can we do? And we've seen it with implementation of vaccine, with a new therapy against COVID, which was a new threat. And in fact, Gilead was one of the first to bring some therapy there. So that working together has happened. And we need to take the learning of the COVID so that we make it continue in a genuine way. So, few examples. So on the first part of my slide, I'm talking about the hepatitis C elimination program. So here we are partnering with, not only with the NHS, but also with third party towards a goal which is very clear and common, which is the elimination of hepatitis C by 2025. So here it's clear. In fact, to make it happen by 25, we need to make sure that we are monitoring because it's just tomorrow. And we've seen that that common goal is really federating people, because we could be one of the first countries reaching that goal. We can't let the momentum down. And so Gilead has invested in not only resource, but also expertise to work in two areas. And we are one of the industry, but I have to say other pharmaceutical companies have also partnered with the NHS to make it happen. So I will only talk about the experience from Gilead because it's the one I know best. And we've done two things. We focused on drug treatment services. And in the drug treatment services, what we've done is we've worked with a team of about 25 people. And we've created a patient access to care team who are going into the centers, identifying the needs there, and see how we can do to make sure that the linkage to care and the time from testing to treatment is optimized. And so that was done also with the third sector. And depending on the area, the third sector active in that area was different. So we really had to adapt the support to the needs there. And just to give you a few figures, over the about nearly 2 years past, what we've done is about more than 100,000 tests, reaching more than 2,000 patients, identifying and treating them. And we know by research that we've done that when a patient with hepatitis C is treated, the quality of care and their return to a normal life is just significant, and nearly about 80% make a significant change. So what we've done there with the PAC team, streamlining the patient pathway, has been very significant, and we continue. In fact, there will be a forum, because not only we are looking at the patient pathway, but we are facilitating events where we're putting the NHS, the third party, the peers, all together and looking at the data, because now we have created data so that we can know where, for example, we have identified and diagnosed patients, but they are there not having care. So then we look at the data, and based on the data, we adapt the support, and we make sure that we accelerate the care. So it's really adapted. And we facilitate, because here, putting the same people in the room, and I was there that day, you could see the energy, and people were sharing a lot of practice. So that was one example, and it's still ongoing, and we'll have another facilitation meeting very soon to make sure that that momentum continues. In the prison, we've partnered with Practice Care Group, which PPG, which is a group of prison, and the NHS and the Hepatitis C Trust. And what we've done is we've done two things. One, it was to improve the testing at reception and identify if it was a treatment was needed, and then making sure there was a treatment there, or creating, depending on the prison, they wanted different things, have a highly impactful weekend where we would test everybody and make sure that they were treated. So in fact, we've again invested in regional leads to train and implement these localized test and treat pathway. I have to say that during the time we've done more than 160,000 tests, about 2,500 people treated, and we are on track to eliminate hepatitis C, not in 25, but in 24. So in the partner prison, so really big impact there. So based on these two examples, the learning are, when we have a shared objective, trust, transparency, and the ability to constructively challenge each of us around it. I'm not saying each of us, in order to improve the patient pathway or the patient outcome. I have to say that is really that is a key of success. So what it means, the right people engaged with a champion. Because when we've seen is when you have a champion, they drive innovation. Because driving innovation is driving change, and for that you need really an element of leadership. Robust and timely data, because very often the data exists, but it's not in the right place and it's not visual. And sometimes just to put something very visual, and we've done that with HIV lens, we've done that with RITC, it's so clear, we identify the solution when we see the data in the right way. And for me, based on this learning, I believe that the industry can be an agent of change also and innovation, because we can pilot things. So let's talk about something. Deborah, you tell me that I would like to see if it works. We pilot it. And then if we see it works, then the key thing is to scale it up and make it sustainable. Because it's not good enough having a little thing, something that works and then let go. It's really making sure that we are also partnering for the scale up and the sustainability. And working on either a short-term or long-term goal, but being very clear at the beginning about what is the focus to make sure that there is a difference for the patient. So to conclude, I would like to say that there are other options for future partnership. I'll give two examples. One, I was very proud to see that England was one of the first countries to implement CAR-T for lymphoma patients in 2018. And in order to implement that very innovative way of working, it's very innovative technology, the industry had to work very closely regionally and nationally to make sure that we were qualifying center, making sure that they were able to do that new technology. Since then, more than 5 years, very soon, have passed, and we need to continue to take the learning. And the industry, not only Gilead, but the industry is working with the cell and gene therapy catapult, which is a group which is bringing all the different partners to make the change. And we take the lesson about what are the lessons to come to that point where we have demonstrated that with new technology, we can generate very significant improved outcome for patients. But then it's more to be done. How can we make sure that we have an equal access and referral to patients, that the right patients are referred to have improved outcome, but also to see how we can update the vision and make sure that the UK remain a leading country for high technology. So here's one example. The other one is about HIV retention and care. You've talked about about long-term care. And here for HIV, we know that when people living with HIV stop their treatment or interrupt their treatment, their quality of life reduces, and more importantly for the community, they are transmissible. They are transmitting potentially the virus to others. So here it is really important to make sure that we help people living with HIV to remain in care so that they continue to have a normal life. For that, often you need peer support, you need data, and you need to have a very aligned agenda in the NHS, but also the local community. So all that to say, some example of things that have worked, lessons, and what we would be very happy to continue to move. And for us in Gilead, the equity of care for everybody is really paramount.
Thank you, Veronique. Really good, I'm going to say summary, but you've covered a lot of ground there. Really good summary of some of the work that you've done and the lessons from that. And for me, a really good reminder that what we're talking about here is not necessarily doing just new things. There are some great initiatives already taking place by Gilead, by other companies that we can build on and that we can learn from. And that's the kind of conversation I want to move into in the second half of our webinar now, is kind of let's roll up our sleeves. We've got the IQVIA experts, we've got industry, we've got NHS in this room. Let's start to look at what some of the challenges and opportunities are. We've got some questions coming in. I might just take one of those now, but I was going to say with the questions, it doesn't have to be a question. Throw a challenge in. If you're sat there, NHS or industry side or wherever you are, and you've got a particular challenge that you want to put to our panel, a problem, a hurdle you're encountering, let's throw that in. Let's talk about that. So I know Jim and Steve are going to kind of set the scene for some thoughts around how we then take this forwards. And whilst they're doing that, I'm going to launch our second poll, because I want to hear all of you who are watching us, I want to hear your thoughts around what you see as the biggest challenges around collaboration between the ICSs, the NHS and pharma. Now we've given 5 options here. There's probably many, many more. The options we've given is industry compliance, industry access to the right NHS people. Is it lack of NHS resource and capacity? Is it lack of industry resource and capacity? Or is it just general experience and capabilities in collaborative projects? Or is it something else? If it's something else, just put it in as a comment. We will pick that up. So cast your votes on that as we go through these few slides, and then we'll open this up to a broader discussion. So Steve, Jim, back over to you.
Thank you very much. Looking forward to hearing the results of the polls in a second. Yeah, I mean, I think, wow, I mean, we've touched upon a large number of kind of opportunities and challenges that are there to be solved. I mean, one of the things, hopefully the screen's moved on for everyone now, and one of the things that I think certainly feel like a real area that has to be, I suppose, worked on in order to make a success of this is the transparency and governance that exists around these sorts of projects, that people are on the hook for their success and are accountable for what effectively gets delivered, but that is done in a way that I think everyone is on the same page from the start. And I think that ability to sort of be transparent to everyone, to sort of know where they stand in a governance structure that actually is there to enable collaboration is where we, I think, often see the really successful outcomes of these types of projects. So Jim, I don't know whether you...
Yeah, I mean, for me, transparency and governance has to be paramount and have to sit at the centre of what we're trying to do. And I think there's real opportunity for life science organisations to support and to bring their programme management skills into the NHS to support with that. It needs to be co-designed. It needs to be a true partnership, as far as I'm concerned. And things that we need to think about, what is the governance structure? What is the risk register that we need to create? What's the privacy impact assessments that we need to make sure that are in place? How do we inform our patient groups that this work is going to be occurring? What's the exit plan? Is there an exit plan? And what does that then look like when we taper away the resource? And what's the reporting and data? And I think, Veronique, you said access to data and being able to articulate the impact is so important when you're working on programs of this nature. And it's really interesting to hear Veronique talk about scalability. There's a number of there's an expression from Southern Ireland that I love from the HSE, and it's the notion of shift left, stay left. And it's about moving away from from acute activity into preventative activity. And I think if you think Scotland have said something similar, which you do once for Scotland, which basically means it's not about pockets of excellence, it's about how do we drive scalability. And in some way, the Core 20+5 initiative is designed to do something very similar. What's absolutely key, and Deborah mentioned, is maybe the health inequalities agenda is because of the acute crisis that the NHS is facing at the moment. That's the bit that's been left behind within the NHS. And I think there's a real opportunity for life science organisations to come in and say to the NHS, let us help you with addressing the inequity of care that might exist. How can we support you with that?
Yeah, just to jump in, I think there's something around we've got as the last kind of point on this slide, the sort of legacy. I think that people having that sort of clear view of actually what really are we trying to achieve together is a very, very important starting point, because that should then help us, to Jim's point around the data that's needed to be able to measure what success looks like. I mean, if you think about actually, there are kind of many benefits to these types of projects. If we look at things like the Target Lung Health Check program, there's an example of the NHS is really trying to sort of push the ability to diagnose people earlier with lung cancer, realizes that actually, lung cancer is one part of the lung diseases that are out there. And we need to think kind of more holistically around how we actually start caring for people better who have other comorbidities around their lung cancer. And how can we actually start putting them on a pathway that is going to have a sustainable impact? And I suppose this then goes back to the scaling point. If you're solving something and kind of identifying people a bit earlier and collaborating around a project to make that happen, which is very exciting, and the sorts of things we know you can use data to do now in bringing people sort of further sort of upstream into the sort of primary care area. But actually, it then probably means that there's going to be an impact somewhere else. So possibly in secondary care, if you're going to sort of identify people earlier, then actually you've got to get them diagnosed and send them into that part of their care journey. And I do think that that's where this kind of holistic perspective as to where collaboration can be centered, which is that it's solving an overall problem rather than just kind of identifying somewhere that you can help, but then kind of leaving the issue potentially further upstream that needs to be addressed. I think it's kind of this legacy. What are we really trying to fix through these sorts of collaborations, and how best to do that across that care journey? I mean, the points around social care as well being brought into the mix here is really important, and often gets, I suppose, not the attention it deserves. I think a very exciting time to start looking at that, and the capability and competencies around what are needed to do that. Definitely something that can be brought to the fore of it.
So we have some great questions coming in, and keeping one eye on time, I'd love to get some of these questions. I think they touch on some of the points that we've talked about already. So one of the questions is around missed pathways, which we've touched on, and whether the panel feels the backlog, the long waiting times for treatment, and indeed diagnosis are contributing to this kind of missed pathways. I'm looking at you, Steve. It was raised during your presentation, so I'm putting you in the hot chair for that one.
Yeah, I think the incomplete pathways, and this goes back to kind of what are we trying to solve, and if you,
it might be helpful just to put a bit of clarification on it. An incomplete pathway isn't necessarily a missed pathway.
Yeah,
it just means that we haven't got to that endpoint. And we talk about the sort of early diagnosis, which is a target that is in the NHS plan. Obviously, we want early diagnosis. The earlier you catch disease, the easier it is to treat. But we're doing that at the same time as reducing backlog, and that's why there's been this massive increase in those incomplete pathways, because we're trying to pick up disease early. We're trying to recover our long-term condition management at the same time as we're trying to treat that massive backlog in patients. And any sort of health, pharma and industry can give into that process, whether it's managing it, dealing with health inequalities, coming up with new and innovative ideas, telling us helping us to stop things. We're absolutely hopeless in the NHS at stopping things. We start new things all the time, and we layer upon layer things, but it's not often that we get input externally to reduce things, and that's the way that we need to tackle and pick up that backlog. So yes, COVID has had a massive impact on it, and that impact will be there for the next few years. When it's going to take a good while, unless something changes, 10 years probably before we recover fully from the impact of COVID.
So can I jump in there? So back on the example of hepatitis C elimination in drug services, because we managed with the NHS to put the data together and we were able to identify per ODN where really the pathway was potentially broken, or what was the reason. And depending on where it is or what is the reason, then the intervention is different. So it's really not trying to have the same brush everywhere. And that's where that ability to have data, which is timely, accurate, and localized, allow us to do a better diagnosis of what is needed. And that is where we can work much more in collaboration. So having that data not only allowed to monitor the progress, but also potentially to say, okay, we readjust.
Yeah, I think that's a really good point. There's something that we observe, obviously spending our lives with data in this company a lot of the time. And I think it's important to make sure that actually, from a collaboration perspective with the NHS and life sciences, that the data availability is not a prerequisite to the success of these projects. So because actually you're building some level of inequality into actually how we can get these collaborations going. So I think there's this sort of ability to make sure that there's available data that exists in systems and databases at the moment that are useful, but actually there is potentially a collaboration around curating data for making sure that we can kind of measure the impact that people, patients are receiving, and as a result of these collaborations. And I suppose that's where, it's that long-term view of how these collaborations can take place that I think Dev, you made the point of stopping and starting.
Mm.
I mean, actually, the real opportunity here is to make sure we don't stop and start these projects, that actually we see them through, and the commitment is there to make that happen. So that in itself, there will be challenges, and it is different in different parts of the country to make a success of these things. But there's that commitment to see it through, and that's the sort of capacity and support and expertise I think that life sciences can certainly bring to the mix.
And the other thing, we have also positive learning of the COVID situation, because I don't think before COVID we were really thinking virtual consultation where possible. And in fact, it is making a difference for some patients in rural area who don't have such access and mobility to see that we can also have virtual consultation that are working. And if I take the example of HIV, people living with HIV, they have benefited from that, where they didn't have to go back to the hospital to be treated as they used to be before. The NHS were able to treat them with one face-to-face meeting per year, and the rest being consultation either with nurses or with so here it just showed that we could lighten the pathway to make sure that the patient have what they need, because sometimes patients are happy to come to the hospital, but sometimes they're very happy to have their not their distance, but have it lighter, because it's something which is long term, just what is needed, which is also reducing the load on the NHS, but also listening to the voice of the patient.
Just a point of clarity on the stopping and starting. What I mean by stopping things, so we introduce something better comes along, but we don't stop what we did before. And the resource, but both in terms of consumables, non-pay, but also management time, clinical time, on trying to do both. So that's what we're not good at. And I think there's real opportunity. Resources can be a barrier. We're not going to be able to change the funding model of the NHS. We waste a phenomenal amount of money because of that funding model, that stop-start at the end of the financial year. But we should be able to regenerate some of that resource if we work more cleverly together to be able to say, actually, you don't need to be doing that anymore, because this does it differently. And it's harnessing that element, I think, is really important.
I think it's a great point, because the reality is nobody, whether they are industry side or NHS, is sat on their hands waiting for things to do. We all have plenty to do, so you can't do new things without stopping some of the things that maybe aren't working. And to the point about data as well, if we're collecting that data, there's also a risk, let's be honest, of starting something that has been done before and hasn't worked, and you don't know about it. So that understanding what's working, what isn't, is immediately relevant, but also longer term. I'd like to move on to another issue if I can, because there's quite a few questions coming in around this, and it relates to the poll, which I'm going to end and show now. And I'll caveat these poll results with the fact that I think we've probably got more of an industry audience listening or watching this than we do NHS. But the question was around the biggest challenges around NHS to pharma collaboration. 43% saying industry access to the right NHS people, 21% saying lack of NHS resource capacity, 28% mutual experience and capabilities. But I want to hone in on this industry access to the right NHS people, because there's quite a few questions coming in around this. Some people clearly frustrated, saying, I work in the industry side, I've got something good, I can't engage, I don't know who to speak to. But also a really good question saying, how is the NHS encouraging staff on the other side to come to the industry with ideas for collaboration? And all the great discussion we're having around what we do can't happen if we get those people together in the room and start that conversation. So I'd love to hear your thoughts as a panel around what is key to doing that, knowing everybody is super busy, no one's got spare time. How do we forge those relationships? Jim, do you want to pick up on that?
There's a few points on the previous slide where we talked about the ingredients, but one of them has to be relevance to the pathway, in terms of impact, and what I like to call kind of how difficult it is to implement the new pathway that we're proposing. Is it disruptive or is it complementary on the pathway? These are the things that we really need to think about. The other key component as well is I would challenge industry to truly, challenge the value proposition that they have developed, and to see whether it is going to deliver what the NHS thinks or needs or wants. So there is a question. There's a question around that. I think just on the third component, I would say, and I'll go to Deborah next. I think it's really refreshing for Deborah to be here to say, I'd love to get to a point where the NHS is pitching to life science. You say, look, this is what we need. And I think we're starting to get there. I do think we're now starting to see that. I think COVID, absolutely right, has kind of brought that collaboration, I think, more closely over the last few years. So, Deborah, I don't know if you have any thoughts on that.
Yeah, I absolutely agree with that. And COVID, we moved mountains with COVID, both within the NHS and partnerships. And we are in danger of losing that step up, and I can see it already materializing, because people are sort of down into delivering and that real pressure of that backlog. So in terms of how do we get people working together, it is about going back to the slide that I had about what are the key drivers: workforce, demand, and finance. You need to be able to pitch around how what you've got to offer addresses those issues, rather than I've got an idea, how can I sell it and make it retrofit?
Yeah.
And in terms of who, I mentioned about ICBs working more closely together, transformation teams, the clinical leaders in the system, those are your key partners. And I think if we concentrate only on health, we're missing a massive opportunity. The real way to address health inequalities and to play the long game is around population health management. So engagement with health and wellbeing boards and councils and local populations is vital. And that's where some of the data comes in, which would be really helpful. You can target some of those discussions and conversations with people who are really struggling with an area. So if you're talking about digital, go to the rural areas. There's a massive problem with rurality, and they're often quite rich populations, and therefore they get less targeted than inner cities, but they've got a huge impact on digital. So it's about trying to join those dots together.
Yeah. Steve, Veronique, anything to add to that?
Well, I suppose mine's more an observation around, I think the life science industry has been very good at engaging with the clinical community in the NHS. But Deborah, you just call out, transformation teams are fundamental to actually delivering and being on the hook for driving change within the NHS. And often that's probably a mixture of people in your role, so operational roles and clinical teams working together. And I suppose a question back to you, Deb, but I just wonder how familiar you were with the opportunity to collaborate with life sciences in these sorts of ways. Was this something you would have known how to have done, or?
Absolutely not. And actually, I'm really excited to be here today. It's opened up, just even in this conversation, it's opened up a real opportunity. And I've been thinking away of all the things that I can ask to help us solve some of our issues. I think we need to do something about raising that profile.
Yeah.
It is, it's well versed in some areas. It's not well versed in others.
Yeah, because on Jim and my slide, we've got a number of kind of practical steps, the kind of the sort of prerequisites and examples of what works well. But if you don't know you can even get to the point of collaborating, it doesn't matter how good your governance structure is.
Yeah, we've got to get away from the view of lots of people, not all, that industry, pharma and life sciences come to the NHS with a big, huge bill. So yeah, we've got this lovely thing that we can sell you, but you need the money. And you've almost hit a barrier straight away. And it's getting past that barrier. And that's about that early collaboration and coming and having a conversation about, so what are your problems? What are the sort of things that you're tackling? What stops you solving that? And then generating that conversation. And I think having more things like this, more opportunities to draw in the NHS in conversations about how we can meet some of those solutions would be great. But it has to be done with the financial envelope in mind, because that unless we can get over that, then we're not going to make that progress.
So I agree, and yeah, what you're mentioning, in fact, is a cultural shift in both for everybody. In fact, it's not only the industry, the NHS, the third party, but it's also how can we bring the patient voice much more closer to the scoping. So what is it really we want to make as a difference, so that we know what is the ultimate goal, and we know it is meaningful. And very often it can be looking at underserved community or community who have not a voice. So if I take, and sometimes it is things that we don't think of initially. And for example, would we think that there is an ethnicity-related inequality in cancer care? People will not think that, but in fact, when you look at it more clearly, we can find that
It's massive, actually.
yes, it exists. And sometimes it is because patient facing cancer, I'm thinking about breast cancer, would think, well, that is not in my community. And or because they don't know how to access the system. So here I'm thinking about the migrant. They arrive in a country they don't know how to access care. So each time, if we really want to address inequality of care, it is important to hear what is the problem. So we understand the problem, and once we have a better understanding of the problem, we're more likely to be successful. And the more we are successful with partnership, the more appetite there will be, and that will feed that cultural shift.
And that cultural shift is needed in the NHS as well, because we still often think we know best. So we have a duty to engage, we have a duty to consult, but sometimes it's done very much as a sort of tick in a box. I hate to say it, but it does happen. And there's a little bit of a fear of consulting and sort of joint working with public, because we often can't meet the expectations. And so people are scared of doing it together rather than separately, and making sure that we do it and to get the best outcomes is absolutely vital for us to move forward.
And I think that whole discussion is incredibly important, and it's always dangerous to try and summarise such a complex discussion. But what I hear from that is I can feel a lot of frustration from the industry side around who do we speak to, we don't know who the right people are. That's entirely valid, but what I hear from that conversation is it's more about what you're saying. It's understanding that what the industry is bringing to the NHS is going to help the NHS, but also help patients, which is that mutual desired and joint opportunity. Easier said than done, I accept. It doesn't take away the challenges of getting in front of the right people, but that positioning, that dialogue is really critical. And one other question I want to get to before we run out of time, and this is more for you, Veronique. So somebody acknowledging, which I guess is good to hear, that Gilead's been ahead of the curve around this kind of collaboration and the programs that you've done, but wanting advice around how you engage internally with the board to get the folks within the company on board around this kind of activity. Anything you can share there?
I have to say it's easy in the sense that in our mission, and our board are very committed in doing a lot to reduce inequity of care everywhere. So for example, for HIV, our objective is continuing to develop HIV treatment and prevention, and everything we can do to potentially have a cure and eliminate. So it's very strong in our board. Where I would say it is really important when we start is to have very clear goal and very clear governance, so that we can demonstrate that we are doing it in the right way, ethically, where we keep arm's length very clearly with patients, that patient safety is looked at, and that all the rules of industry are adhered to, because we are a very governed industry for the right reason. So here, to answer the question, what do we do with the board? It's having very clear and transparent goals and transparent governance, so that we can see we can do what we do in an ethical way and with the benefit for patients.
And I guess also outlining there's a benefit for everybody involved and good in the patient benefit,
Yes.
but for the company, NHS,
It's a mutual
everybody
win.
wins.
Yes.
Yeah, fantastic. So one more follow-up question. I know we're up against time. Just to pick up on a point that you made, Deborah, there's a question around how does the industry help the NHS overcome this fear, I guess, of engaging? Tough question. Any thoughts on that?
I think there needs to be some upfront recognition of what those pressures are and how the discussion can and the solutions can help address those. So again, it is about pitching. It's about, instead of pitching a product, a solution, a proposal, it's about pitching against or to address those pressures in the NHS, and then you sequence in your solution. I think hitting transformation teams, clinical leaders in ICBs, well, we work more collaboratively now than we ever have before. Still a challenge, but in terms of how the old commissioning organisations was very much a sort of an us and them. We work collaboratively around those solutions. We are struggling more than ever in trying to meet the needs. We can't do things without some different input. So attacking those sort of, how can you help around workforce? How can you help around resources? And even if some of that is around the movement around financial years, how can you trial things and have proof of concept? How can you take, by doing things differently, some of that demand pressure away? Those are the things I think that will give the link forward. I mean, it is a huge step to climb, I'll be honest with you. I just noticed one of the comments about really pleased about my open views, but not many have. I was one of those people who didn't have an open view. I used to absolutely dread seeing a drug rep or a sort of a consumable rep meeting with my cardiac consultants when I worked in cardiac services, because I'd have planned my year, I'd have planned my budget, my activity, and I'd know that there was somebody coming in with a big bill. So you've got, that shift needs to happen. When I think the only way that we can have this happen is by more conversations. And I'd be interested actually in how you'd manage to advertise this webinar to the NHS as well as to industry and pharma. And I don't know what the proportion of views are, but again, it's having a sort of better advertising of what we can do and these sorts of conversations that will make the difference.
Yeah, well, I certainly encourage, I mean, this webinar will be on demand once we finish the live version. I certainly encourage people, whether it's NHS or industry side, to listen to this conversation. I think it's a great starting point. But we started this webinar talking about the time pressures on the NHS. We've unfortunately got our own time pressures because we're up against time. But I wanted to give each of you just a chance, and I know it's very hard to kind of summarise such a broad discussion, but summarise, what your key takeaway is from this, or for somebody who's watching this, whether they're industry or NHS side, any key bit of advice that you'd like to offer, a kind of quick summary of a very big topic. Steve, I'm going to come to you first.
Oh, thanks.
Sorry.
Cheers. I suppose it boils down to perseverance. I think the intent is there and the willingness is there. It's just trying to make sure that actually, overcome some of the hurdles that are actually going to make these sorts of exciting projects, programs, come together. So I think it does take a bit of perseverance at the moment, especially because the NHS is in a crisis. There's only so much headroom to kind of go around and think through these types of things. So I think that'd be my simple word for the day.
Thank you, Steve. And Deborah, you've just made some great points. But anything to add to that?
Well, I think the open door is definitely there. We've got, and I hadn't mentioned it before, but NHS England's reduced its staffing by 40%. We've just heard that ICBs have got to shrink by 30%. Those pressures, everybody is going to be looking now for ways to help deliver the outcomes and the care. The transformation expertise, the data, the modelling, all of those things are real opportunities to help support those those discussions. Everyone's really busy as it is, so trying to do that much the same amount of work and solve the same amount of problems with less staff is going to be a challenge. So I think there's going to be more opportunity for people wanting those conversations.
Thank you. Veronique?
So I would like to keep the momentum we've got during COVID, to see in fact that partnership is possible, a true partnership is possible. Key element of success is the careful scoping at the beginning, finding the right people. And I can understand why my colleagues in the industry, sometimes we have the impression that we can't find the right person and the right champion. And once we have the right champion and the right scope, then we monitor, we adjust. And then the one thing we need to add is celebrating success, because I think when something works, we forget to mention it. So celebrating success and also sharing it so that more patients can benefit. And ultimately, we are reducing the inequity of care everywhere.
Thank you. And Jim, I'll give you the closing word on this.
Closing word. So I might take a few, but that's okay. So one is, I think life science companies really need to articulate their medical mission and align it to the NHS agenda. I think the second real opportunity for life science companies is to build what I call beacons or exemplars of excellence in certain geographies, and then to act as the lift and shift, the conduit to bring that to other parts of the UK. And I think that is a real key role that life science can play in supporting the NHS.
I love that.
Thank you. That seems like a
Beacons
nice way to end things. And I mean, look, my simple summary of this, I think it's been a fantastic discussion. I feel very privileged actually to sit in on these conversations. I think if there were more of these conversations happening, I know there are many that are happening around the country, this is the perfect environment for finding ways to work together that benefit everybody. So thank you to all of my panel for taking part. Thank you to all of you who've been listening in, watching, sharing your great questions. I'm sorry if we haven't got to your question. We've got a lot of questions coming in. I've tried to cover as many as I can. And as I mentioned earlier, this webinar will be on demand the minute that we finish. So if you've missed any bits or you think it needs to be watched by colleagues, please share it on. And I'm sure there's questions that, as I say, we haven't got to or come to your mind after this. You've got the contact details on the screen for Manisha Banway to IQVIA. You can send questions to her that we can channel through to Veronique, to Deborah, to the IQVIA folks. If you want more details of the PESHL analysis that we showed earlier, or the other IQVIA analysis, again, contact Manisha. She can provide those details. But once again, I just want to say thank you so much for joining us today. Thank you to my panel. Thank you to all of you. And we'll hope to see you next time. Thank you very much.
Thank you.
Thank you.
Thank you.